Thank you so much, Adam, and thank you as always for the very kind introduction. It's always my pleasure to do any talks on OCT-Angiography because for those of you that know me, you know that I'm extremely passionate not only about OCT, but about OCT-Angiography. I feel like this is really the way that we can take the best care of our patients. So let's jump right in. I really just wanted to start off with a shout out to Optovue, which is now Visionics. We all know that Optovue has been in this industry really since the very beginning. This is a company that has been dedicated to OCT excellence really since the early 2000s, and I've been extremely fortunate to be able to work with them. They're an extremely bright, innovative, intelligent team who's always looking out for the best interests of the patients and the clients. For those of you that have Optovue, or maybe you don't have it, they're the first company that came up with a spectral domain OCT. They're the first company that came out with a combined anterior posterior segment OCT. They're the first company that came out with OCT-A, and really the icing on the cake is that they have what we call angioanalytics, which allows us to quantify the things that we're seeing on OCT-A, which we'll go into tonight. This is the only company that has angioanalytics, which really makes the interpretation so much easier. This company also has full range retinal features, which allow for taller and wider scans, meibomian gland imaging, and what I didn't add on here is brand new topography. So this really is a multimodal imaging modality, not just an OCT machine. So just to give kind of a brief introduction on where we have been and where we are now, you know, back in the early 2000s, for those of you that are as old as me, you may remember time domain OCT, and this was really huge in the fields of optometry and ophthalmology because for the first time, we were able to get a non-invasive cross-sectional image of the retinal and choroidal architecture. But as you can see in the image, you know, there was a lot of pixelation, a lot of questions regarding what we essentially were seeing in the image. So a couple years later, spectral domain OCT came out, which really just allowed for more scans per second, which provides for higher resolution, higher quality images. The tricky part was that these images only allowed for visualization of retinal anatomy. So if we wanted to visualize perfusion to the retina, this would require a referral to a retina specialist to get fluorescein angiography or, you know, some other test that would allow us to actually see what was happening down at that capillary level. So the OCT companies decided, you know, or I should say Optovue Visionics decided, let's come up with a way to allow optometrists that, you know, don't inject to be able to visualize this. And this is where OCT-A really came in. So in 2014, first OCT-A was introduced, and you can see that the image looks completely different than what we see on regular OCT. So if you can see my arrow here, you know, this is called an OCT-B scan. This is called an angiogram. And you need to use B scans to obtain an angiogram, which we'll talk about in just a minute. So pros of having just a regular OCT-B scan include, you know, excellent visualization of macular and retinal architecture. It's a non-invasive test. It's extremely easy to perform. But to summarize what I just said, you can't visualize flow here, right? This is a static image giving us information strictly about architecture. So if you're looking at something like a drusen or something like fluid, or essentially any elevation or disruption in the retinal tissue, OCT-B scans are going to be phenomenal, right? It's going to give us excellent visualization of that. But what if I wanted to see if a patient was ischemic, right? What if I wanted to see if they had a loss of blood flow from a vascular occlusion, or if they had too much blood flow from a choroidal neovascular membrane? Those things are not going to be able to be visualized on OCT, thus allowing us to see, or really the utility then of OCT-Angiography. You know, we used to say it allows us to look at the function of the retina, which it partially is true, but what it really does is allow us to look at the capillary bed at looking at either too much or too little blood flow. So here is essentially how this works. This is a motion contrast system. So it's based on the premise that the retina is a, let's say, stationary object. The only thing that should be moving within the retina is retinal blood vessels, or red blood cells, I should say, not retinal blood vessels, red blood cells. So what we do here is we take sequential B-scan images, which you can see on the left here, okay, two or more depending on the technology, but we're taking sequential B-scan images. And what the machine is looking for are differences in reflectivity or differences in signal between those two B scans. The idea is that, again, the only thing that should look different between sequential B scans is something that's moving. So the machine has an algorithm or a way of looking at these two stationary B scans and picking up on differences in reflectivity. So the image in the middle we call a flow overlay image, and understanding how to use that flow overlay image in the interpretation of angiography is crucial, because what you're seeing on that flow overlay, anywhere where there's red or pixelation, are areas where the machine said, I see differences in the reflectivity between the scans, essentially meaning that there should be blood flow in those areas. So in the inner retina, it makes sense that you should see pixelation because we have our capillary beds running within the inner retinal network. And you should see pixelation down in the choroid because we know that our choroid is all blood flow. What you shouldn't see is pixelation or red in areas that are avascular, for example, the vitreous or the RPE, right? Those are areas that should not have pixelation running through them. So when you're trying to figure out if a patient has an abnormal area of vascularity, you need to look at that pixelation. So from this flow overlay image, en face cuts, meaning horizontal cuts, are taken at different levels of the retina and choroid to obtain these angiograms. So angiograms essentially can be made from any area of the retina and choroid to the smallest micron size to really visualize what's happening at this vascular level at each and every part of the retina and choroid. So just to kind of think of this in a different way, if you look at the retina, which you can see in the middle here, if you were to take en face cuts through the retinal anatomy, so if I was going like this side to side, I would be cutting through different capillary networks. So if you were to look at the most superficial capillary network of the retina, we'd be looking at what we call the superficial capillary plexus, which is really looking essentially at, let's say, interlimiting membrane through interplexiform layer. So what you're noticing there is the capillary bed that innervates the superficial retina. The blood vessels are in white. This black area in the center is your foveal avascular zone, which is where there's no blood flow. So easy to understand, where you see black on an angiogram, no blood flow. White is blood vessels. As you course further posterior through the retina, we're going to hit what we call the deep capillary plexus. And you'll notice that the caliber and look of the blood vessels or capillaries look very different than in the superficial plexus. A lot of retinal diseases actually start or originate in the deep plexus, and this is a really fascinating thing about OCT-A because the deep plexus is not well visualized on fluorescein angiography. So this is a hot topic because there are diseases like, retinal angiomatous proliferation that originate in this plexus, and if you can't see it, then it's difficult to see where the disease process is starting. And as you continue to move further posterior, you hit what we call the avascular outer retinal zone, which really correlates with the RPE. So that's not a mistake that it's black. It should be black because the RPE is an avascular tissue. And then finally, you get to the choriocapillaris, which should be a white, spongy, homogeneous angiogram because that is all made up of blood. So understanding what these regular slabs or regular angiograms look like is very, very important as you start to move through different pathologies. This is a beautiful example here of this technology of Visionics' technology of how amazing the images are. So these were taken on the Solix, which is the newest technology. You can see that there's a 6.4 by 6.4, which means 6.4 horizontal by 6.4 vertical. 9 by 9 gives you, more depth, more height, and then 12 by 12. And you can see on the right a very wide field angiogram, which is just the clarity is outstanding. You can look at those capillary vessels and just, I look at them, I still don't ever get tired of looking at these. It used to be that in geography, we had to be careful when we got to these wider scans because we lost a lot of the clarity. We lost stuff as the image became bigger, and that's no longer the case. So it's so much fun now to image things that are not just in the posterior pole because we can actually visualize them with a ton of precision. This is what the angio-retina report is going to look like on the Solix. I just wanted to share it because it really provides just a ton of information. On the top right and the top left, you can see fundus images, which this machine also has. So you can correlate your fundus image with your OCT and OCT-A images. There's B scans, there's thickness maps. Down the center, you can see the angiography, all the different plexi that we just talked about. On the bottom, you can see all of the metrics. Everything is put into a quantitative form. And there's a color-coded normative database map that you can see on the bottom right. So really nice way of looking at retinal pathology. If you don't like what you're seeing on one image, or you want to see it in a different dimension or in a different light, there's many different ways that you can look at it. You can also click on tabs to look at different things on these features in more detail. So I think that the thing that everyone's on here tonight is to understand what we're doing, how we're looking at OCT-A to really take the best care of our patients. And I want to start off kind of looking at what we call intraretinal disease, which are diseases like diabetes, and then we'll spend the end of the session looking at outer retinal disease. So I've used this example many times, but really to me highlights beautifully what this technology does. So I can't emphasize how important it is to become familiar with the norm. So on the top right, I have their image, the superficial and deep capillary plexi. Why? Because those are the two plexi that feed the superficial retina, or the sensory retina, okay? So when you're dealing with intraretinal disease, it's not all that important to be looking at the avascular and choriocapillaris slabs. We want to be looking more at these two slabs that feed the sensory retina. So in diabetes, these are the slabs of interest. So what are we looking at? So on the bottom, you can see a patient that's diabetic. It's not hard to see the things that look different, but you'll note that there are areas of darkness, particularly around the foveolae vascular zone, but the red arrow is pointing to a nice area of capillary non-perfusion. So our diabetic patients don't tend to have as much perfusion as patients that do not have diabetes. So we're looking for these subtle areas where the capillaries are what we call non-homogeneous, right? We're missing some of that homogeneity because there's ischemia in those areas. We're looking for microaneurysms. Microaneurysms are these little, what the yellow is pointing at, will be capillary outpouchings. Those are areas that, again, clinically you'd see as a red dot, but on angiography you can see increased hyperreflectivity correlating with that. Also an enlarged foveal avascular zone, because remember that an enlarged foveal avascular zone means not as good perfusion, right? If you have a tighter foveal avascular zone, you have better perfusion to that area. So looking at these two slabs, you'll begin to notice subtle areas where patients are not getting well perfused. And this is really something that happens before we see anything clinically. So you can see a patient and tell them that they are doing really, really well. And I'm going to show you an example. And then you go and you do angiography and you're like, oh my God, there's so much non-perfusion here. That basically means that that patient is going to go on to develop retinopathy in a matter of time. So here's an example of a patient. This is a 45-year-old African-American female, and fundoscopically, everything looks really, really nice. And you'd have to really start imagining, maybe there's one MA there, but really looks healthy. The OCT B scan structurally looks fantastic because the B scan's correlating with what we're seeing, clinically. So you say to this patient, all right, you're doing amazing. I'll see you back in a year. Keep up the amazing work. We send a note to the primary care physician. Your patient is doing outstanding. But really, here's the question, is this patient doing outstanding? And I would argue that any patient now that is diabetic that you're getting an OCT on, you should be getting OCT-A on as well. So here is just kind of a picture of an on-FOS kind of storyline of this patient over time. The color-coded map there shows you, how things are changing. But what I wanted to really show you was the angiography. And you can appreciate here that there are quite a few areas of capillary non-perfusion. The foveal vascular zone is certainly enlarged and irregular, almost amoeba shaped versus ovoid. And there are microaneurysms here in the deep capillary plexus, which actually is where a lot of these microaneurysms originate. So how would you change your conversation with this patient? Well, I think it's obvious, instead of telling the patient that they're doing really, really well, now we're getting, it's almost like we're taking all the clothes off of the retina and we're looking at it in a naked view. We're looking at what's happening underneath, and there's really so much happening subclinically. So I'm sure that a lot of people are thinking, how would this change my management? And we can talk about that later on if anyone has questions, but certainly I would see this patient back before a year. And more importantly, the communication with the primary care physician is what needs to change, right? The education to the patient needs to change. Their behaviors need to change. And this is what you don't want to happen. Hold on, I don't know why I'm not advancing here. Oh, sorry, they're on my arrows. This is what you don't want to happen, right? So you ask yourself, if I don't do anything differently and I allow this patient to go on with the behaviors that they have and, I don't communicate with the primary care physician, will they look like the bottom in a year, right? And that is what we don't want. So the way that we behave before that happens is of the utmost importance. Let's look at another example here. This is a 45-year-old glaucoma suspect who's been diabetic for 5 years, and they come in and they tell me that they have poorly controlled blood sugar and they're having trouble with every medication that their doctor has put them on. So they're aware that their diabetes is not under the best control. Fundoscopically, I'm not impressed, right? This doesn't look terrible to me. There are a couple of anomalous vessels, but to be completely honest, this would not be on my radar. I see much worse than this every day. I give a blow up here just to show you that, yes, there is some anomalous vasculature, but, I don't even see, maybe I see one hemorrhage or one, little tiny microaneurysm, nothing that's yelling out to me. And I'm blowing up the macula for a reason, because, I keep looking at this and I say to myself, does it look abnormal to me? No, it really doesn't. But if you overlay the angiography on it, what are you noticing here? It's totally irregular. Remember that the fovea vascular zone should be ovoid in shape. There should be homogeneity to the capillary network around in that parafoveal area, and we do not see that. So this means that this patient will go on to develop retinopathy. It's going to depend on the time for the patient, but something will happen in the future for this patient. And this is another example, and I'll kind of rewind and tell you what we call this, but this is a 55-year-old African-American male, similarly had no diabetic retinopathy on fundus exam, but his vision's decreased to 20/50. And, you look at the patient and you say, well, you can think about this patient here, you say, well, I don't really see anything, fundoscopically, everything looked okay, B-scan looks okay. But if you do OCT-A, you're noticing here that things are not okay. And we call this macular ischemia. Macular ischemia is not the same as macular edema. Macular ischemia means that there is no perfusion or poor perfusion to the macular area, actually resulting in decreased vision. And the unfortunate part about macular ischemia is that anti-VEGF treatments are not efficacious for this, because we're not treating any kind of fluid here. We're treating an ischemic process. So these are patients that have gone too far, right? These are patients that we're not identifying clinically. We're identifying them on angiography. And think about it. If you didn't have angiography and you had this 55-year-old who did not have lenticular opacities but had decreased vision, what would you do? So this is something else to keep in mind. This would be a referral, because you can't certainly sign off on a chart on a patient that is 20/50 with an unknown reason for having that decreased vision. So macular ischemia. And just to kind of highlight here the difference in resolution between FA, which is on the left, and OCT-A on the right, I'd like to call attention just to this this vessel right here, which really gets lost on the fluorescein angiography. Fluorescein, shows leakage. OCT-A does not, because it's only imaging things inside the blood vessel. So the clarity of the images is really unsurpassed, just because you're not getting that noise in the background. One more example here of a diabetic 50-year-old. She's been diabetic for 10 years with an A1C of 5.9, and she's 20/20 in both eyes. So, looking again pretty quickly at her, she looks fantastic. Vision's excellent. A1C is under control. So, at quick glance, this patient's in good shape, except for the optic nerves, which we're not talking about. I'm blowing up the maculas here because you're going to be quite shocked and surprised when I show those to angiography. But, maybe if you're looking very closely, especially on that left eye, you may notice that there are some anomalous vessels. And here's the OCT scans not showing anything, right? Remember, from an anatomic standpoint, these B scans are normal. The fundus exam looks fairly normal. Here's the OCT-Angiography, right? Quite shocking, right? This is the superficial plexus of the right eye. You can see that this patient has an anomalous foveolae vascular zone, but more importantly, look at all the microaneurysms hanging out there, all of those anomalous blood vessels with little bulbs on the end. I was shocked when I saw this. You know, I go back to the picture and, you know, I saw something weird there, but certainly wasn't expecting this. This is the deep plexus of the right eye. Similarly, you can see all those anomalous vessels. This is the deep plexus of the left eye. See, this should be the superficial, but and then here's a multi-scan view. So you can see here what I was really curious about this patient. I wanted to know what would happen over time. So I had her come back a couple months later. And what you'll notice is that, you know, the foveal area certainly doesn't look very much different, but pay attention to this area right here. I mean, this is showing you that here's a patient that is getting more ischemic over time, right? There's more areas of capillary non-perfusion. So these patients will progress. And notice that the B scans on the bottom are completely normal. And this is the left eye. Similarly, you know, you look at these, the foveolae vascular zone doesn't look too bad. Still a bunch of areas of capillary non-perfusion. I'm not as impressed in this eye as I am in the right eye that there's been that much of a change. Here's another patient with some messy looking retinas, a 62-year-old Indian male, diabetic of 20 years with high blood sugar levels, with a recent decline in vision, right eye worse than the left. And obviously there's a ton of retinopathy here. Kind of get lost in the mix here. I think we would all agree that this looks like severe NPDR, maybe with some PDR, but again, a lot of noise. So I get a B scan through different cuts. This is one that I chose to share with you. And you can see that there's an abnormal area living in the vitreoretinal interface, which correlates with neovascularization. So I wanted to just show you on the OCT-A how that would look. It's kind of cool. You can see that there is pixelation running within this abnormal network. Remember that anywhere that you see pixelation is an indication that there's active blood flow. So that's not fibrosis. There's active neovascularization within that area. And on the segmentation map, this is the superficial plexus. You'll notice here, all of this is neovascularization. Note the heavy amount of non-perfusion neighboring these areas of neovascularization. There's also an area up here. Foveolae vascular zone looks actually probably the best part of the picture, but notice how dark. I mean, the whole angiogram is completely non-perfused. Similarly, in the left eye, you can see this area over here on the B scan that's living in the vitreoretinal interface. It has pixelation running through it, another indication that there is some neovascularization there. And just look at how cool this is. I mean, 1, 2, 3, 4, all of these areas of neovascularization. And, you know, if you're paying attention and looking back and forth at the fundus image, it's not as clear on the fundus image as it is on the angiogram of all of these areas of proliferation. So if you're looking at an image and you're not sure, is it neo, is it IRMA, angiography is going to give you the answer. Another patient here, you know, you look at this and I say at fast glance, it doesn't look too bad, but I want to call your attention to this anomalous area right here. And I bet each of you has had a patient like this in your practice that you're looking at and you say, well, it's a diabetic patient. I don't really see any retinopathy, but yet I see this kind of weird maze of blood vessels. What could that be? And so, you know, here's the OCT-B scan. The OCT-B scan is highlighting that you've got these little buds of neovascularization. Remember that whenever there's pixelation, you have blood flow running through this. So guess what? This is neovascularization. I mean, who would have thought in a quiet retina? And this picture still to this day is one of my favorite. This is a big area of neovascularization. What I did here is I moved my slab to the vitreoretinal interface, which highlighted this huge area. Not only this area, but guess what? There was another one up here as well. So here's a patient that's so ischemic that they developed neovascularization in the absence of really any other clinical findings. So if you allow this technology to help you, it really can be a game changer, because if I had seen this patient and I wasn't sure, then I really wouldn't know what to tell the patient, right? I know that there's anomalous vasculature, not really sure what's going on, but the angiography really drives the point home. This is just an example of how this technology allows you to kind of use a color-coded map to highlight areas of neovascularization. So I just wanted to show you how the neo here kind of highlights it in green. It's just another feature of the technology. Another one here, you know, I'm showing you cases that I'm sure everybody that's watching tonight has had situations like this. Here's a patient that has, again, a lot of dot and blot hemorrhages, a lot, quite a bit of retinopathy, and just a lot of anomalous blood vessels. Like look down here, you've got these, just a lot of stuff, and what are you going to do with this? Are you going to hold it? Are you going to refer it? So the B scan on the bottom right shows you kind of something living at the vitreoretinal interface, and you say, well, could that be neo? Is it just some, remnants of the posterior hyaloid? I'm not sure. What do I do with that? Well, move your slab to the vitreoretinal interface on OCT-Angiography, and if it is neo, you're going to see a frond. So that is on the top what it would look like if the patient had neovascularization. So again, understand how to use the technology, move your line and your scan right through these anomalous vessels. And here's a highlighted image. You can really appreciate here what I was looking at, and I didn't know. Is this patient proliferative? Are they severe non-proliferative? Certainly I think we would all refer this if we weren't sure. Another example here's a patient that has this area. Remember that when you have this red pixelation, it's an indication that there's active blood vessel growth in there. And look at this. Look at all of the neovascularization here. Okay, so just a lot of really pretty examples that I've been able to capture using this technology, and really drives that point home that it helps us to make better diagnoses for our patients. And here, just like I showed you with the non-proliferative, here's an example of PDR on fluorescein versus OCT-A. Remember that neovascularization is going to leak on fluorescein angiography, kind of obscures the image, whereas you can beautifully visualize here the curly Q features of OCT angiography. Just some other really cool pictures before we move into outer retina. Looking at retinal vein occlusions, you look at these and you ask yourself, is this ischemic, non-ischemic? What is the likelihood that this patient's going to go on to develop neovascularization of the iris, of the angle? So here's my different OCT-A images of patients that have had vascular occlusive disease. I just always, like I've been telling you, I'm so fascinated by the clarity of these images. You can certainly see the amount of capillary non-perfusion on each of these that correlates with the area of ischemia. Some of these you can, visualize these anomalous vasculatures, which likely these patients might, especially this one, looks like he went on to develop some neovascularization. This was another really cool case, the branch retinal artery occlusion. I saw this patient in 2010. I actually just recently saw him back. You can see how the area of disrupted or sick retina looks significantly better 14 years later. But here's the question: do these patients ever recover? Does this patient have good function in that area? So I just wanted to share with you because I thought it was really cool. We got an OCT-Angiography over the area, and you can see here that, yeah, clinically he might look better, but he still, is lacking a lot of blood flow within that segmental area of the artery occlusion. And you can also appreciate how atrophic the retina got. It almost is like half the size of a normal retina. And that's the deep plexus. Remember, these intraretinal diseases are going to be best illustrated with the superficial and deep capillary plexi. And then for angioanalytics, I can't tell you how important it is. This company really shines in this area. These are the different ways that you can analyze patients using angioanalytics. You can measure, using metrics. You can use colors. I'll give you some examples as we go through this. Here's an example of how we can measure foveolae vascular area in normal eyes versus diabetic eyes. And they give you a metric on top here so you don't have to guess. So as the patient's foveolae vascular zone gets larger, that's an indication that the diabetes is getting worse. And again, you do not have to measure it. The machine automatically does it for you. This is a patient that you can see over time from 2015 to 2017, what's happening with the foveolae vascular zone. Look at how these numbers started at 0.171. The perimeter, meaning this area around the foveolae vascular zone, was 1.767, and you can read these yourself, but these numbers are significantly growing over time, really indicating that there is more capillary non-perfusion as this disease progresses. Here's another example, same idea here, just with B scans, and on top you can see how the level of retinopathy is getting worse. You can look at non-flow areas if you're interested. You can take your clicker and, click on different areas, and you have like kind of a color-coded way of assessing areas of non-perfusion. You can use vessel density. We know that the warmer colors mean better perfusion. So what you're noticing here is a patient that has mild NPDR, has about 56.2% perfusion, and that number is going to decrease in density as the amount of ischemia gets greater. So just a lot of different ways that you can assess how healthy the eye is. And you can use this vessel density map to assess patients over time. These will give you quadrant analysis, really based on saturation of patients in different areas over time. Once again, vessel density is going to significantly decrease as the disease severity increases. Okay, so let's skip over to outer retinal disease now. So remember that outer retinal disease, a perfect example is something like age-related macular degeneration. And remember that now we're looking at the avascular or area around the RPE and the choriocapillaris. So we're switching gears now, we're shifting to the lower slabs because these disease states or these disease processes happen lower down in the retina. So here's a 65-year-old Caucasian male, and I'll just kind of talk you through, like we would do with diabetes, what we'd be looking for. He has a history of dry AMD with a recent change in vision in the left eye. And I'm not going to spend a ton of time on this, but you can certainly see that this patient has a ton of medium to large soft drusen. Definitely in the category of intermediate AMD, may even have, more advanced disease. 20/40 on the right, 20/50 in the left. So in the right eye, you can see the multiple large drusen. On the OCT-B scan, remember that here you can see that the RPE is lifted up. When the RPE is lifted up and you have this homogeneous appearance underneath, we call that a drusenoid PED. What we're looking for, any areas of abnormality that might suggest a choroidal neovascular membrane. So this is a beautiful case of how I would use angiography, because I look at this and I say, well, the photoreceptors look a little funny over here. Is this patient beginning to get some kind of abnormality? So I would get angiography, and I can see here that the outer retinal slab looks normal. It's black. The choriocapillaris slab has these darker areas within, which is really just what we call a shadowing artifact, which means that we're kind of cutting through the drusenoid PEDs, but there's no area of abnormal vascularity in the right eye. So the right eye, I'd be satisfied to say, has intermediate dry AMD. The left eye, which was the eye of concern for the patient, I said before, it looks like there's multiple large drusen, but the fundus image does not suggest anything that looks like it's bleeding or any areas of geographic atrophy. When I get the OCT-B scan, I can see, there's definitely some drusenoid PEDs here, but what is this, right? Does this look normal? Well, it didn't look normal to me. The area was extremely large under the RPE, and then there was this darker area here. Any darker area adjacent to a drusen is suspicious, right? We should always be suspicious that there's some type of abnormal vascular pattern there, because you shouldn't have fluid anywhere near a pigment epithelial detachment. And I'm circling this area down here because what you'll notice is that within this abnormal PED, there's red. When you have a drusen, like here, here, and here, you'll notice that there's no pixelation running within the drusen. Here, you can see that there's increased blood flow in that area, which really concerns me. And that was what I was telling you before, is that you have to also learn to look at your flow overlay images for areas of increased pixelation and areas where perhaps they shouldn't be. Why would you have increased pixelation within a pigment epithelial detachment unless there was blood in there? And then here would be the angiography that, the RPE slab looks fine, but look at this little guy right here. This is telling me that there is a choroidal neovascular membrane. All of these are shadowing artifacts from the drusenoid PEDs. But this little guy right here, this lacy hyperreflective area, correlates with this very anomalous area on the OCT-B scan. So I would argue that, I feel pretty comfortable looking at OCTs, and this is a case that I wouldn't have been sure, right? This doesn't look normal to me, and the OCT angiography solidified the fact that this patient has a net or a membrane, and that is not visible on the fundus image. Here's another example of a 63-year-old African-American male who came in for a glaucoma workup, fundoscopically very unremarkable. We got 2 retinal scans as part of the GCC analysis. The horizontal scan looks completely normal. The vertical scan, I picked up what I call this little blip, right? Wasn't sure what I was looking at there. I said, oh, maybe it's a drusen. You know, it certainly looks like it's between RP and Brooks membrane. Honestly, I wasn't that concerned about it, but I had just gotten OCT-A and I was interested to see what this would image like. I was expecting to get a shadowing artifact like here, right? Because that's what drusen does. But I was shocked because when I ran the OCT-A, I found this little baby guy. And I think this picture always shocks myself and my audience because not what I was expecting. On the flow overlay image, notice the increased area of pixelation correlating with this kind of anomalous area. Here it is again, right over here. And the challenging part about this, at least when I started learning about this, was that there was no hyporeflective area like we saw in this patient. Let me go back for a second just to show you the difference. In this patient, there was this area here, which is an indication that there's some exudation or fluid coming up from the choroid. In this particular patient, it was quiet. I was seeing that there was a blip living here underneath the RPE, but there was no area of fluid associated with it. So I thought to myself, well, how could there be a membrane here? And, you know, we've come to coin this term called non-exudative membranes because these are choroidal neovascular membranes that are not exuding. So something to keep in mind, they certainly necessitate a retinal referral. Whether or not they're going to be treated, that is in the hands of the retina specialist. But OCT-Angiography has done a brilliant job at identifying these lesions that we cannot identify on OCT alone. And I just want to show you some other, you know, amazing features of this technology. This is I started off by kind of explaining the word full range OCT, meaning you're getting taller and wider scans. So here's a patient that has high myopia. There's a staphyloma, and this is an image taken by the machine. It does have a camera capability. And we all know that it is extremely difficult to image high myopes because of the concavity of the retina. A lot of times you just can't see what you want to see. Well, because these scans are so tall and so wide, you can actually capture both the optic nerve and macula and a whole bunch of retina in one scan. And here you can appreciate the staphyloma right here, this hyperreflective area. So a beautiful example of how one image on a very challenging patient really gives you so much definition. If you look at this orange thing here, or this orange rectangle, that's essentially what you would see if you did not have full range features, because you're not getting, you might get the width of, you might get the width, but you're not getting the height. So you're missing, you know, a huge chunk of that B scan. This is another picture of a degenerative myope. I hate that word, but patient that has high myopia. And you can see here again how we're getting the optic nerve and macula in one cut. And when we look at this image, hopefully you're asking yourself, well, why is this area of hyperreflectivity living right under the macula? And we know that patients that have high myopia are prone to getting choroidal neovascular membranes. So here's a patient that I would get OCT-A on because I got the B scan. It's recognizing that there is an anatomic abnormality there, but I cannot see blood flow using just OCT-B scan. So here's a patient that I would go ahead and capture an additional image on to see if there was any choroidal neovascular membrane, and guess what? There it is. So this is, again, this is the flow that I do in clinic, right? I'll start off with the B scan, I'll assess it. If there's something that I want to look at in more detail, or if I'm trying to evaluate further, I'll go ahead and get OCT-Angiography. And this is just a brilliant capture of a patient that had a choroidal neovascular membrane from pathological myopia. Remember that the wider fields of view allows for better visualization of CNV. So if you have a choroidal neovascular membrane and you have a smaller scan size, you may miss visualizing the entire extent of the membrane. Even though this is the abnormal membrane, all of this around it is abnormal tissue. Remember that the choriocapillaris should look like this. It should be homogeneous. So when you have this darkness, this is all abnormal tissue. Potentially it could, you know, become involved in that choroidal neovascular membrane. So understanding how to utilize these bigger scans is really helpful in patients that have CNV. I also just want to give a yell out here again, looking at the pixelation. Notice there is this increased blood flow here in this area, which is an indication that this patient has active blood flow within that area of hyperreflectivity, which is actually the bleed. Here again, we've got some B scans and, they don't look all that bad to me. The RPE certainly doesn't look healthy. We might have a sick RPE here, but who would have thought, looking at these B scans, that this patient had a choroidal neovascular membrane? Well, guess what? They do. So, nice examples here of what would you think if you saw this. And what we're appreciating here is these areas here where the RP is slightly lifted up. We're not particularly seeing any form of exudation. So this might be another example of one of those occult non-exudative membranes where there's stuff going on, but we certainly don't see a whole bunch of fluid in the surrounding area. Look over here how the RP is very, very subtly lifted up. This here is Brooks membrane. If you're watching this and you look at this and you say, well, I wouldn't have identified that. If you had OCT-A and you were running them simultaneously, then guess what? You wouldn't have missed it, right? So these are very, very, very important examples of things that we don't want to miss. Even if we think we're super good at looking at OCT, these are examples of patients that, unless you're stellar, none of us are perfect, that this might be missed. This is another example of just a really amazing wide field image. Look at the vitreous. I mean, this is a beautiful example of the anterior contraction of the posterior hyaloid. More importantly, this patient has what looks like a choroidal neovascular membrane. There's some fluid-filled pockets here. And here is the OCT-Angiography. And remember that you can look at this in so many ways. You can look at it with your outer retinal slab or choriocapillaris slab. You can do an en face cut, which really allows for kind of another way to visualize blood flow in this abnormal area here. And then this is showing you one of the features of the angioanalytics where you can actually take your cursor and you can draw it. You can click around the lesion and the machine will automatically tell you what the area is of blood flow there. So if you're trying to determine, if a patient is doing better over time, each time they come back, it will automatically line up the image in the same place. You just have to put your cursor and kind of color it in and you can see how these images are doing over time. Geographic atrophy has been a huge topic of conversation over the last year or so, and OCT-Angiography is gaining ground as far as helping us to determine what's happening at the level of the choriocapillaris and what is the potential for progression in patients. So you can see here that if you have a wider field OCT-Angiography image, then you can visualize the full extent of the lesion. Whereas in the good old-fashioned days of OCT-A, I would argue that this little box in the middle was what we were seeing, and we'd be missing really the full extent of the lesion. So this is a nice example here of this is actually dead tissue, right? What we're visualizing here is down to the choriocapillaris. We're visualizing area here where the RP and retina has been stripped off from this atrophic process. And here's the just an example of an en face cut right next to it. And the last case that I had recently is this is a 55-year-old African-American female. She was asymptomatic and I did 9DD and I said to the student, this looks funny, she's 20/20, but there's something weird going on in that macular area. And you can see here my concern, right? There's this kind of pinkish elevated lesion here. This was done on the Solix camera. Patient had extensive hypertensive retinopathy, but more importantly to me, not more importantly, but I was interested in seeing what was happening at the retina, at the level of the macula, because she was 20/20. And, these are her OCT B scans. Really did not indicate too much, but again, hopefully you're getting good at this now. Why is there increased pixelation here underneath this little PED? So, again, PEDs should not have increased reflectivity. There shouldn't be any area of increased vascularity. Just like this one is clean, this one should be clean. You shouldn't be seeing this area of increased pixelation here. And I went and got angiography, and it's really subtle, but this patient had this little baby membrane here, right there, and I magnified it to show you it over there. And here's my little increased area of pixelation. So, pay attention to these things. If you had this patient, and you weren't 100% sure and you got the B scan and you're looking at it, it looks like a drusenoid PED, have a nice day, you would have missed something. So, try to, again, introduce these new technologies. Don't be afraid to introduce these new technologies to help to pick up some of these more subtle images or some of these more subtle findings. And this is a really nice example too of all the different ways that you can put together information that you capture on this machine. You have your fundus photo over here. Here's your angiography, here's your B scans, and there's multiple other options on top here that you could also select. Here's another example of just to show you this little kind of nugget here. This was the bleed right there. And here's my little choroidal neovascular membrane. I was just showing you different slices, different angiograms. I'm going higher up into the retina here. I'm at the level of the yellow. And this is just another example. I was playing around with it. So that is it, Adam. Hopefully everybody has somewhat of a better understanding of OCT-Angiography. I'm happy to answer any questions that may come up.
All right, well, thanks so much, Julie. That was great. And if anybody has any questions, on the right side of your screen, you'll notice there's a box there where you can ask any questions, and I will verbally ask them for you. So let's see. I guess I should do this chronologically. I suppose it's probably the fairest thing to do. So here's a question. If your OCT-A can get the ONH, you can also see if there's decreased blood flow to the ONH, which does this assist in decision-making of OHT versus POAG? Huh.
So that's a glaucoma question.
Yep.
So I will answer by saying that OCT-Angiography in the glaucoma space is still somewhat new. I'm going to be honest, I don't use it that much for my glaucoma patients. I need to get better. I'm being honest. I need to get better at doing that. So my answer to you is that ocular hypertension likely will have normal perfusion to the nerve, whereas a patient that has glaucoma is likely going to have some infarct. But you are correct. There's something called the radial peripapillary capillaries, which is what feeds the optic nerve head. So the same way we looked at the capillary blood, the network and the retina, you have the RPC that feeds the optic nerve head. And what you'll notice in glaucomatous angiograms is that there are sectoral areas where there is no perfusion. Whereas in ocular hypertension, essentially there should not be that. So it certainly can assist. I didn't include that in this lecture because I wasn't focusing on optic nerve head, but yes, it can assist.
Right. Interesting question here. So you said in the presentation that fluorescein angiography does show leakage from a vessel, but OCT-A does not. How come?
Okay, so the way that OCT-A works is it's looking at the movement of red blood cells within a blood vessel, and it's looking at sequential frames to see what looks different between the frames. And again, that's using motion contrast, looking at the movement of red blood cells. Anything that's not within the blood vessel is not going to be imaged on OCT-A. It only images what's moving in the blood vessel. So if you have a hemorrhage, it's not going to show up on OCT-A. That is something that's coming out of the blood vessel. The only thing that it will image is something like a microaneurysm. Neovascularization images because it's new blood vessel growth, so it's blood within a blood vessel. But anything that's coming out of the blood vessel, like fluid, is not going to be imaged.
Right. Question here, and this is funny because we were talking about it right before we went on the air. What's the new code for OCT-A, and what's the projected Medicare reimbursement?
Yeah, we were just talking about that. I don't have answers to that yet. That is, It should be coming out shortly, but we don't know that yet.
Yep. And I mean, it is an important point, though, if people are unaware with what's going on, right, that there will be this code and there will be a reimbursement that the government's going to announce very soon.
That's correct.
Yep. So I guess the answer is stay tuned. Yeah, I mean, it's good actually. It's you almost feel like the regulatory framework hadn't really caught up to the technology, and now they finally are.
Correct.
So, question here. So, is OCT-A good at detecting early hypertensive retinopathy?
Yes. I mean, you can look at so hypertensive eyes are not going to have as much saturation of vessel density as you have with a control eye. I wouldn't say though that clinically that's something that I'm doing regularly. But yes, if you were to look at studies on eyes of hypertensive eyes versus control eyes, what you'll notice using, let's say, the angioanalytic platform is that if you were to use a color-coded map, you certainly wouldn't have as much bright, warm colors as you do in a patient that doesn't have high blood pressure. But as I said, unless the patient has some kind of vascular occlusion, it's not something that I'm regularly doing.
Right. So question here, early in the presentation, you mentioned that the Solix was the only OCT that has OCT-A metrics. So can you just explain a little bit about what that is and why it's kind of unique?
Yeah, so basically, if you have, let's say you want to measure the size of the fovea vascular zone, this is the only company that will give you a quantitative number of the size, let's say, of the FAZ. So other companies, you can look at the FAZ, but you have to eyeball it and say, oh, it looks like in 2022 it was this size, and in 2024 it's this size. This company does the metrics for you. All you have to do is kind of tap on the outskirts of the FAZ and it will give you a measurement. Same thing as with a neovascular membrane. If you want to measure the size of it, or if you want to look at how much flow is going on through the retina, or if you want to look at density, so saturation, how much capillary perfusion is there, it gives you a color-coded metric. The other technologies, may have angiograms, but you have no way of knowing just by looking at it how saturated is the retina, how much is this area not getting perfused. Does that make sense?
Yep.
So it's numbers and colors that are providing you with assistance in interpretation.
Yep. And oh, interesting question here. I mentioned actually in the beginning, you wrote the book on this literally. Question here is, where can one pick up a copy of the book?
Oh, yeah, that's cute. It's on Amazon. Slack is the publisher, but you can get it on Amazon too. Just type in Rodman OCT-Angiography book and it should come up.
Oh, awesome. And related to glaucoma, this question is, what are the best resources to learn the GCC norms on OCT?
Well, that's gonna depend on the technology, the device that you're using. So I don't necessarily, I don't know a number to tell you. There's not a normative, each company has a normative database for their technology. So when you are using this, let's say you're on this machine, the color-coded metric, like red, yellow, orange, whatever it is going to tell you where that patient's number falls compared to the normative database. So it's not like we look at RNFL and we say, yeah, the RNFL should be above 80, 85 microns. But when you're looking at GCC, or a lot of the other parameters, we're looking at the patient comparison normative database. So that's when those colors come into play. And I could go back if you want. I think it was like my fourth slide where I showed you the retina overview, the printout, and how there's different areas with different colors. That's basically how that patient compares to the normative database.
Got it. Oh, interesting question here. Does OCT-A have diagnosis application in ocular ischemic syndrome since the lesions are in the mid-periphery?
Yeah, I would tell you that that's a tricky one because now you have to get really, really far out. So even though this technology will go up to about a 12 by 12, you can do a montage though. I mean, I'm thinking as I speak. If you do a 12 by 12, you're not going to get far enough out to see the capillary non-perfusion. But if you were to do a montage, so this technology allows you to you could get a bunch of 9 by 9 montages and put them together. So you could make a really, really big picture. I would think that you'd probably be able to see the capillary non-perfusion out there. I haven't done it myself, but with the capability of stitching together multiple images, likely you'd be able to see it.
Right. And that actually brings me to another question here. You're talking about montages. How long does it actually take to get an individual scan? So let's say you did want to throw together something like a montage. How long would that actually take?
Montage is a different story. An individual scan is pretty quick. I mean, you could get a 12 by 12 in probably, seconds. I mean, if the patient's a good patient, under a minute, you can get the scan. Montage is different because you got to have the patient look in different directions, and then the machine will slice them together. But I'm going to be honest, when you have a 12 by 12 scan, it's usually more than enough for what I need to see. Now, peripheral retinal disease is a different story. If you're suspecting a patient has peripheral retinal disease, peripheral retinal ischemia, that's a patient I'm going to refer out. I'm not going to sit and try to piece together images. What I want to see, the stuff I want to see, is more than enough with the 12 by 12.
Great. All right, and it looks like we have used up just about our whole hour, but Julie, thank you so much for being here and doing this. And we're going to put an archive of this presentation up on ODwire. So if anybody has any more questions, and I know that there are more coming in that we're just not going to be able to get to, we can put them up there and we can continue the conversation there. So Julie, thanks again for doing this.
My pleasure. Good luck to everybody. And I'm always available to answer any questions that anybody has. I know it's a little frightening at first, but it'll be worth it in the long run.
Excellent. Okay, well, thanks so much. And thanks everyone for showing up tonight. And I guess I'll see everyone online. Good night, everyone.